Alright, so this is the next portion. I believe we are on section 3 or 4 of the digestive tract at this point. We are going to talk about pathologies of the upper digestive tract, and notice that we put GI in here. That stands for gastrointestinal, and I commonly refer to this particular system as the GI system or GI tract. So some of these typical pathologies with the upper digestive system are going to be esophageal pathologies, such as esophagomalacia, which would be that abnormal softening of the esophagus, which, you know, guys, that can't happen. That's going to cause a lot more problems. Esophagodynia, remember that's pain, discomfort. Esophageal varices, these are very, very painful for our patients, and what I want to do is I want to show you these esophageal varices here in the picture. It's like a varicose vein, or almost like a hemorrhoid that's there in the lowest part most of the time of the esophagus. So it's very, very common for these patients that have esophageal varices to not want to eat, not want to drink, because everything hurts. And if you look at that, it kind of makes sense. Really, really makes sense. Same thing with these ulcers that we commonly hear. Now, when we talk about the different types of ulcers, the name that's preceding the term ulcer tells you where that ulcer is. So gastric, of course, pertaining to the stomach ulcer. And then the duodenal ulcer, remember, that's that last portion of the stomach where we start that little tube to go into the small intestines. So those things are not fun. Another term that you might be familiar with in terms of pathologies with the digestive tract is GERD. GERD stands for gastroesophageal reflux disease. Gastroesophageal reflux disease. Now, yes, you do need to know how to spell that. You do need to know that because you are going to write that abbreviation a ton of times. A lot of times your patients will just say, hey, I've got reflux. And hey, guess what? You know what it means now. So there are also some of these different types of ulcers, like the peptic ulcer. And just by this picture, it just makes my skin crawl knowing how painful this must be, having this ulceration here in the stomach, and it just is probably not easy for those patients that have a peptic ulcer to eat or drink, especially things that have spice in them. I mean, you look at that raw tissue and think, oh yeah, let me throw some greasy pizza on top of that. No thank you. No thank you. So let's look at some of the lower digestive tract pathologies. This is where you might see that appendicitis. Remember, we talked a little bit about that. So if a patient needs to have that inflamed appendix removed, they're going to have an appendectomy, and we'll see that in a second. Gastroenteritis, which is basically the stomach irritation of not just the stomach but the intestines as well, which typically leads to dehydration. So we want to make sure that if our patients have that gastroenteritis, that we make sure that they're getting enough to drink so we can balance out those fluids and electrolytes. Then we also see sometimes with a malabsorption syndrome, because the body is not able to absorb those fluids, electrolytes, vitamins, and minerals, the body is just releasing them too quickly. So we got to figure out how to correct that problem. The lower digestive tract, you also have those colitis and ulcerative colitis that I mentioned earlier. Crohn's disease, that is a type of inflammatory bowel disease that's chronic, and that typically causes extended problems. You also can see those fistulas and fissures, and just by those terms you kind of think, oh, I don't want one of those, but yeah, this is what it looks like. Those fissures are abnormal cracks there in that tissue. Here you see those with anal fissures, and as you can imagine, if you are eliminating waste products from your anus and rectum, when you have that waste product, that stool, pass through this area and go past those fissures, it very well can cause an infection. And then on the picture on the right, you've got hemorrhoids, which are varicose veins of the rectum and anus. So you can have internal and external hemorrhoids that can cause your patient pain. That also can cause a little bit of bleeding with bowel movements. This is a good little picture showing you what diverticulosis looks like. And you probably have heard of diverticulitis, and this is the diverticulosis. Alright, and here's a good picture. I love this. I've actually seen this at my gastroenterologist office, hanging on the wall. A nice picture that shows you the different types of problems that we can see within that large intestine that could be problems causing rectal bleeding. So obviously we just talked about the diverticulitis and diverticulosis, that ulcerative colitis, polyps within the lower part of the colon, colon cancer, of course. Then we've got those hemorrhoids and polyps and the fissures that could cause those problems. So some other pathologies of the lower digestive tract. You could see some different infections from different bacteria and parasites and viruses. You probably have heard of people getting food poisoning and developing E. coli, which is very, very common with undercooked meat like beef. There are different types of bacteria such as botulism and salmonella that you get from different types of meat, and we want to be very careful and make sure that our patients, if we find that in their stool, we find out what the root of the problem is. They're probably eating undercooked food. Okay, some more things. We've got the duodenal ulcers, irritable bowel syndrome, and that also now is an irritable bowel disease, but I want you to remember it as IBS, because you'll hear a lot of patients talking about IBS, irritable bowel syndrome, and then you also have irritable bowel disease. Impactions. You know, our patients become impacted with stool because they are constipated, which leads to impaction when they have to do soap suds enemas, barium enemas to alleviate that impaction, or a lot of times it does have to be manually eliminated, and nobody wants that, but it does happen at times. So if you can imagine having an intestinal obstruction, just thinking about obstruction makes you think, oh, no, no, no. That obstruction can be because of an impaction, but the picture that you see here on your screen now is showing you what some of these obstructions are going to look like in some of the causes. One of those that is pretty impressive, I hate to say impressive, but it really is. It's called intussusception. Intussusception. So pictures C and D are showing you intussusception, where the intestinal wall is folding in on itself. So it kind of puckers in like you're going to do a pleat. So when that happens, it causes an obstruction, but it also can cause necrosis of that bowel, which, you remember, necrosis means death of tissue. So it's kinking off the blood supply to that area and can cause death to the intestines there. And of course that is not good. So we would be wanting to make sure that that gets taken care of as quick as possible. Alright, pathologies with those accessory organs. We can see problems with jaundice, which I mentioned earlier, hepatitis, which is inflammation of the what? The liver, right? So hepato is liver. Hepatomegaly, which is enlarged liver, you're going to actually see that diagnosis becoming more frequently used because due to the high-fat diets that we have as Alabamians, if you will, and Americans, we're seeing a lot of patients with hepatomegaly. Then you also have those viral types of hepatitis, which are A, B, C, D, and E. As healthcare workers, we are really concerned with hepatitis B and hepatitis C. So pay close attention to those. There are vaccines that you can take for hepatitis B. Hepatitis C, there is not one to prepare your body for to develop some immunity. But we're working on things. Great that our medical society is evolving here. This is a good picture of a patient's eye that shows you when they have this condition called jaundice, that it causes the whites of their eyes to turn yellow. And remember, we're going to see jaundice with patients that have cirrhosis. Sometimes patients can have cirrhosis of the liver that's caused by alcohol, but that's not the only reason that you will see cirrhosis of the liver. Sometimes that happens because of disease processes such as a chronic disease such as diabetes, and we want to be careful with that. Then you have your hepatic carcinomas, which are types of liver cancers. That will cause that because basically it's not allowing the liver to properly function. Then you have your gallbladder. That's another one of those accessory organs. One of the big things that we want to remember here is the cholelithiasis. And cholelithiasis is the condition where we have gallstones. That's a very important term you need to remember and understand and be able to spell. Yes, hint, hint. So here is a good picture of gallstones. So the patient has had their gallbladder removed. The physician, surgeon has cut open that gallbladder so you can see the stones. They can get pretty darn big. Okay, so let's look at the pancreas, the other accessory organ. We can have that pancreolith or the pancreolithiasis. This is the condition. The lith is the actual stone. You can have, of course, cancer of the pancreas, which is pancreatic cancer. And then you also can have pancreatitis, which is inflammation of the pancreas. All of those can make you very, very sick. Very, 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 very bad. So let's look at some of the therapeutic surgical interventions. Feeding tubes are common with our patients in the hospital. Sometimes they're discharged with a feeding tube, and it is to help the patient to get nourishment when they're having problems with their digestive tract because of some type of disease, some type of removal of the intestinal areas, and this is a way to make sure that they get nutrition, or we are actually having a port for the stool to be removed. So we're going to see that with some of the types of interventions here soon. Bariatrics, you're going to see a lot of new information on bariatric surgery, which is that good old gastric bypass, gastric sleeves, those types of things. So this is showing you the gastroplasty, where we are actually doing two things. You can have the sleeve, and these have kind of gone and done fun things here with the sleeve over here on the right, and then this is the gastric band over here on the left. So you can actually press this button to tighten that band to where there's smaller amounts of food that are needing to be consumed to make that patient feel hungry, or excuse me, full. Of course, some of these others that you've probably heard of, liposuction, Lobectomy. The Gastropexy is the big fancy word for a tummy tuck. It's just one of those things that we do a lot of around the nation. It's part of the mommy makeover, I believe is how they call that. The abdominoplasty is part of that. So the other surgical interventions where we're removing some of those different stones and things that we might see, where we have the chyloplasty, we're removing some different things there, going into Some of the other therapeutic interventions, we're doing antacids. You can get those over the counter. Things like Tums and Rolaids, Pepto-Bismol. Those are easily used and they're accessible nowadays, but you got to be careful when you're suggesting those to your patients and make sure that they're not going to interact with any of their other prescription medicines. The gastrectomy, this is that gastric bypass that we were talking about here. This is really assisting with removing some of that area in the stomach. This is the anastomosis that you will see in your textbook, where you've got the small intestine area coming down here, and we just kind of do a loop around and try to fix that. Okay. I wanted to let you guys look at this, the colostomy versus an ileostomy. And this is just showing you at what part of the large intestines the patient is getting one of those surgical devices implanted, where we can have the waste products, the stool, to be eliminated into a bag that is worn externally for your patient. And the nurses at the hospital and nursing homes, they will actually work with the patient on how to empty that, change it out, proper hygiene, and all of that fun stuff. If you go to work in a gastro office, you're going to learn how to do that as well. So this is what it looks like, the real deal, for the port that goes into the abdominal cavity and goes down to the intestines. And this is a patient showing you how they're changing theirs. So we have to be careful and make sure that that's properly maintained. Okay, some of the other surgical procedures that can occur. This is a great picture of appendicitis. You can see the appendix here that they're holding up. It's all nasty and black, so it's needing to come out. So they'll remove that laparoscopically a lot of times, and then they'll cut it here. They've got things tied off here with the suture, and pull that back out through the hole in the abdomen, one of the holes in the abdomen, and the patient, basically gets out of that procedure with about 3 or 4 holes in their stomach versus a wide open incision, which takes a whole lot longer to heal from. Okay, some of the other procedures, surgical procedures, hemorrhoidectomies. Remember we were talking about how there are internal and external hemorrhoids. Those can be surgically removed. It is a very painful process. And then of course we've got these other medications like antibiotics, antidiarrheals, which is going to work against diarrhea, like Imodium. Antiemetics, remember anti is against, emet is vomiting, and the X is the agent. So an antiemetic is a medication taken to control vomiting. Then let's go to the other end of the spectrum, laxatives. We're trying to encourage bowel movements in the looser stool where it's not quite as tough and hard to pass. These are some of the other types of therapeutic interventions for those accessory organs. We can do a lobectomy, which was removing just a portion of the liver, because you have to have your liver, but we can deal without a lobe of it, so a part of it. We can also use insulin to help lower the blood sugar or raise the blood sugar depending on what the patient has got going on there. We also have lithotripsy, which is a procedure where we go in and with shock waves we break down those Gall Stones that the patient has there in their gallbladder, which helps to make the stones smaller so they can be passed. Then we also talk about these different procedures that are listed here that we can look through the digestive tract and try to make things better. Pharmaceuticals, I'm just going to hit on those very lightly because this is not a pharm class, but notice that we have different types of anti, and ans. So these are working against or no, not, or without and then it's going to describe what it's doing. So an anti-diabetic, we're working against the diabetic condition. Those medications can be used to lower the blood sugar and try to maintain it, and sometimes that insulin has done that. And then again, the laxatives, we're trying to soften the stool, make it a little bit easier. You have your gas medicines. The flatus is gas, so working against gas. You also have some medicines that work as histamine receptors and proton pump inhibitors, so working on that action of producing some of those gastric acids. We want to work against producing too many of those. And then here are some of your abbreviations for this particular chapter. I hope you have enjoyed this. This is the last lecture for the digestive tract.